Good evening. Hi, everybody. My name is Jamie Dunn, and I am the Program Director of Cancer Support Community on the Central Coast. And I'm bringing this live to you tonight from the UCLA office in San Luis Obispo. We're very lucky and fortunate to have two doctors tonight to share this great topic on precision medicine. A special request because this particular talk is actually grant funded, and this helps us to continue to give great free support to all of our local patients and their families with cancer. So part of that grant funding is that we need to get some surveys back at the end of it. So if you're tuning in live, and I'm going to give you a reminder later, we're going to send out a link in the comments section to be able to have you fill that out, send it back, and that helps us tremendously. So I really appreciate it if you give us that little piece to help us continue to provide great services. The other thing is we can make this as engaging as you want to be. So I'm going to be at the computer, and if you want to comment or send us a private message asking a question or making a comment, I will share those anonymously. So I obviously won't disclose what you're asking or who you are, but I know the doctor will be happy to answer some questions as we go. There are a few points where it pauses in the PowerPoint, and we'll make sure we address those. So I think that's all I have to share. So let's welcome Dr. DiCarlo and Dr. Chamberlain. All right.
All right, guys, I'm Erin Chamberlain. I'm a hematologist and medical oncologist here with Dr. DiCarlo and Dr. Villa at UCLA, and we'd love to get started to chat with you guys. All right, so I think we've done some introductions, and we'll introduce Dr. DiCarlo in a little bit. In this talk tonight, we're gonna talk about what is precision medicine, what is biomarker testing, how to use these biomarkers, types of targeted therapies based on all of this, what's the cost, and what about genetic testing? All right, so precision medicine. This is a way of saying, how do we make a therapy for your cancer individualized for you, based on both you and your individual factors, as well as your tumor's biology. So we can keep the next one. Yeah. So if you look back in time and we look at cancer and how it was originally treated, virtually we didn't have a lot of tools in our tool bag. And so we had to take patients, clump them into what kind of cancer they had based on where it started. And we had limited treatment options that were basically treatments that would kill tumor cells in general. We still use these types of treatments. That's often what we call chemotherapy. But we now, based on our advances in medicine, understand the molecular findings of your cancer, or what we call the biology of your tumor, so that we can harness that and use it as a weapon against it with our treatments. So what I like to tell patients about precision medicine and about cancer is that every patient is unique. So just because a patient gets diagnosed, let's say, with a stage 3 colon cancer, it doesn't mean that that person has the same type of cancer as another person with a stage 3 colon cancer. Everyone in this scenario is their own snowflake. And we look at the actual genetic mutations in biology of your cancer, which is unique to you. All right, so to do this testing, what it requires is that we either take tissue from the tumor itself. This can be from a biopsy or from a surgical procedure. In the event that we can't get that tissue or don't have enough tissue, oftentimes we'll actually draw a person's blood. We can send off genetic testing off of the blood, off of what's called circulating tumor cells if present. And very rarely could we do some testing versus in other ways. There's saliva tests, but that's not generally used for your tumor testing. Okay, so different tumors, we are looking for different markers, but in general, we now have an understanding of the different genetic mutations that tumors can acquire to allow them to both grow and spread. And so when we send off testing, we're really honing in on those genes that can be mutated to allow that cancer to grow. All right, so what these biomarkers can tell us. So one thing we can use it for is we can take these tests along the treatment path to see how is our treatment doing. We can also use them to predict what treatments your cancer is going to respond to. And we also can use it to help us understand how this cancer is going to behave and what we predict in the future for your kind of journey on this disease path. All right. It also gives us an idea of how aggressive your tumor might behave. Dr. DiCarlo will give examples of this, but a quick example would be, we know that in colon cancer that a BRAF mutation is going to mean that that cancer is going to grow and spread more quickly than if it didn't have this mutation. All right, so this is a table of a bunch of different types of mutations that we might see on a report, and you might see on a report if you have access to the report that was generated, or perhaps request your record. You can see that this is all in medical language, and so we as the physicians, our job is to help interpret this for you. But in general, what we're looking at are very specific markers on your cancers, and these are a smattering of them in each disease. All right, so I encourage every patient to engage with their physician with as many questions as you can possibly care about. And this is a really good question to ask your physician of, has there been biomarker testing been done? And if so, can you walk me through it? What did it all mean? All right, so I guess we will stop there and ask for any questions.
We do have a little bit of a lag, so I have some hellos. I asked everyone to say hello.
Oh, hello, everybody.
Yeah, we want to get this engagement going.
Happy Wednesday evening.
I know.
I hope everyone is staying safe out there too.
All right, we just hit question time. All right.
Okay.
I'm gonna say we're gonna keep rolling.
Yeah, we'll keep moving on to section 2.
That me?
That's you.
All right. Okay. Hey everyone, I'm Dr. DiCarlo. You guys probably remember me from last year's talk. Probably know a lot of you either as patients or friends. So we're going to go ahead with the talk here. So the next part of this talk is just kind of talking about targeted therapies and what that really means. So what we do nowadays, like Dr. Chamberlain was saying, is when we find a biomarker, one of the reasons to find it is to find a therapy that will attack that weakness in the tumor. So there are a bunch of therapies out now that basically attack a certain mutation that may be in a gene in a particular tumor, or something that shows that it is susceptible to things like immunotherapy. So we can predict now who might benefit from certain targeted therapies. So a couple of ways targeted therapies can work. Tagging cancer cells and destroying cancer cells directly are kind of related in the sense that, you know, chemotherapy can hit cancer cells directly, but now we have what we call antibody drug conjugates, which are these targeted antibodies that bind to a specific protein and then release the chemotherapy into the tumor cell itself. It's kind of a direct delivery of chemotherapy to the tumor cell. A good example of that is Kadcyla, which is common in breast cancer, HER2-positive breast cancer. Cutting off the blood supply to the tumor, the most common therapy that we use is a medicine called Avastin, which basically cuts off the blood supply by blocking this protein that stimulates blood cell formation or blood vessel formation to the tumor. Cutting off the hormone supply to the tumor that many of you may be familiar with. in that for breast cancer, if it's estrogen positive, we often give anti-estrogen therapy. For prostate cancer, we often block testosterone, which can cause cell death in the tumor cells. And taking the brakes off the immune system, this is kind of the most exciting part of oncology right now, which is immunotherapy, which is giving these medicines that block these proteins that are brakes to the immune system. And so essentially releases the brake and stimulates the immune system to attack cancer cells. So we talked a little bit about this. This is kind of the anti-drug conjugate that sticks to a certain protein and kind of releases a chemotherapy in it. There actually are therapies now that use radiation in a similar way. This is kind of similar. We keep going. So we kind of talked about all this already. Yeah, so just give me. Okay. So questions to ask your doctor about targeted therapy. So what are the names of the targeted therapy drugs that I could or will receive? Where and how will I receive my treatment? Is there anything I should know about handling the drug? And how often will I get the treatment? What side effects should I expect and how will we manage them? The targeted therapies tend to have very different side effects than chemotherapy or, I guess, traditional chemotherapy. So they're often very, very much better tolerated than chemotherapy, but they have different side effects. So it's important to know that, especially with immunotherapy. Will I receive targeted therapy alone or in combination with other treatments? That's a very good question. In lung cancer, we are now using a combination of traditional chemotherapy and now immunotherapy. So that's a common thing now. And how long will I need to receive this treatment? Of course, that's different in every patient. Examples of targeted therapy. This is a good list. Wow. So see, these are some of the mutations or biomarkers that we routinely test for. EGFR, ALK, and BRAF, for instance, are often tested for in lung cancer. And you can see for each of these gene mutations, we have drugs that target it. All of these are actually pills. ERPR, which is the hormones, we talked about that are things like tamoxifen or Arimidex, Femara. Many of you are familiar with that. HER2, we have trastuzumab or Herceptin. Perjeta is a new generation HER2 inhibitor. And we have a pill called Tykerb, and there's another one that just came out called tucatinib. And then we have Kadcyla, which is that antibody drug conjugate I was telling you about before. For women who have BRCA positive breast cancer, we have these drugs called PARP inhibitors, which inhibit this enzyme called PARP, which is very important for breast cancer cell survival, but not normal cells, so it's very targeted. ROS1 is another lung cancer marker that has a drug for it. This is one of the more important things, actually. Pembrolizumab or Keytruda is an immunotherapy. And I believe this was the first therapy that was approved in a fashion that we call it tumor agnostic, which basically means that we can use this medication in any cancer that has this abnormality. So basically anybody who has a metastatic solid tumor, in other words, not a blood cancer, should have this tested. And if we have something called MSI high or deficient MMR, they are candidates for this drug. Basically what this means is that the tumor has a lot of mutations that the immune system can recognize, and patients can do remarkably well with immunotherapy. This NTRK gene fusion is a very rare gene mutation, but it can happen in just about any solid tumor, so it basically should be tested in just about everybody. And we have this medication called larotrectinib. There's actually two other ones now available. Very, very effective in that situation. So side effects of targeted therapy, a lot of this is talking about the pills that hit that hit the biomarkers I was telling you about. EGFR is the most common. Rash, dry skin, itching, these are very typical side effects. This is, yeah, thank you. So here are a couple of examples. So HER2 positive breast cancer is probably the biggest or one of the earliest discoveries of targeted therapy. So HER2 is a protein that sits on the surface of breast cancer cells and is overexpressed and drives the cancer in about 20% of breast cancers. And now we have multiple HER2-based therapies. In early stage disease, we use Herceptin and Perjeta, greatly improves the cure rate. In more advanced stage 4 disease, it can control the disease often for a very long time, even many years. This is talking about the limitations of precision medicine. So this is very much a work in progress, and it will continue to improve. Things have changed dramatically even since the talk that I gave last year. There's probably about 20 different new targets at least. There's multiple new therapies since in just 1 year. Things are changing at an amazing pace right now. So it's really important for us as oncologists to be very up on the changes and the new discoveries and what can help patients. Benefit some but not all, that's important. We have to look for a targetable mutation. One of the things to know is that even if we do not have one, there are some that are being looked at in clinical trials. So we can always look for something new for a patient. Not all subtypes have a targeted therapy. Even if your tumor has a biomarker that matches, it might not work. And targeted therapy isn't a cure. I'm not sure I agree with that. So in a lot of cases that's true, but there is, immunotherapy can increase the cure rate. HER2-based therapy can increase the cure rate substantially. So it depends how you define cure and define targeted therapy. Questions?
Mm-hmm. They have questions about insurance coverage and cost and things, so I'm thinking that might be actually upcoming more.
You can help me with those ones.
So nothing related to what you just spoke on yet.
Okay.
So you're welcome to kind of keep going, and I'll pause if we need to come back to it.
Okay.
Okay. Do you mind being my clicker?
Yeah.
Okay.
Okay.
All right, so it sounds like you guys are interested in this part, as I would expect. So cost of biomarker testing, it can be expensive. It's not a guarantee your insurance is going to cover it. In some cases, yes. In some cases, no. And in some cases, you pay part. In clinical trials, if they require biomarker testing, it's not a guarantee that test is paid for by the clinical trial, but that is something to check in with if that is part of the clinical trial. And then this is really important. So I always tell patients, if you get a bill and that bill says somewhere between, oftentimes what we hear from these companies is these tests can cost between $2,500 to $5,000 for one of these tests. If you get a letter with that bill directly, I encourage patients to bring that to us because we may be able to help sort this out and direct you to the right places that might help you pay that one. All right, so this is a guarantee. So find out what your insurance can covers. Oftentimes that's done after the fact, but if you can do it proactively, that's very helpful. And then the other reason to bring it in is that if we can't get support to cover a huge cost on this, we can go to a company and see if they might be able to assist. Okay, so on to, should we answer some of the questions that came up for cost before genetic testing?
Just about insurance, does it pay for testing?
I will say this, so as things are rapidly expanding in this world of precision medicine, the FDA is catching up and they, on a regular basis, are saying that that the American Society of Clinical Oncology is recommending that all patients with certain diseases in certain stages get tested. And then what happens is those insurance companies are saying, all right, it's now a new guideline. We are going to cover this. So that's something to keep in mind, that is in flux at all times.
Another question was if there are certain testing companies that are more reliable than others, or if there's one that's generally favorable.
Yes, that's a good question. So there's a lot of different companies that offer these types of tests. Some of the bigger or well-known companies that you may have heard of are called Foundation One. There is Guardant. There is Caris. So those are just 3 of the major companies that we use. Sometimes your provider will choose a company based on the gene panel. So while all the gene panels are very similar and roughly will cover around 30 to 35 genes that are known to, if mutated, result in cancer, each one has different nuanced differences. And so we might use a company for a certain disease type or stage and a different company for a different disease type or stage. Also, it depends on if we're getting a test based on the tumor tissue itself, or if we're doing it off of your blood draw. That might sway our decision on which company to use. And then lastly, even more nuanced, if we want to test what's called the RNA versus the DNA, some companies offer the RNA testing. And the reason we would do that is that Dr. DiCarlo had mentioned the NTRK mutation. That is often an RNA test, a gene fusion test, so we might have to go to a certain company that offers that. Okay, any more questions that we should answer? All right, so genetic testing for inherited cancer risk. So we can proceed. All right, so at the first appointment, often when you are newly diagnosed or presenting to a new doctor, we will go through your family history. And for some patients, the family history is very telling that we need to clue in to the fact that your cancer might have been passed down from your parents. In other cases, the disease itself is high risk enough to be inherited from a parent and their genes that in that case, regardless of family history, we're going to recommend testing. So in each particular cancer type, there are guidelines to help us understand who should get genetic testing. So when a patient is diagnosed with what is called inherited cancer, or we say you inherited this tumor from your parents, what that means is that your parents passed on a genetic mutation to you that may or may not affect your siblings or your children based on which genetic mutation that is. And that's what we mean. What's really important is that based on these biomarker tests, if we find that your tumor has genetic mutations, those genetic mutations based on those tests are unique to your tumor. It doesn't mean that those are in your DNA that you inherited from your mom and dad. All right. So this is the point I was making, and I get this question a lot of, you're telling me that my tumor has X mutation. Do I need to talk to my parents or talk to my kids? The answer is, in that scenario, no. Okay, so the reason I get a question of why do genetic testing, either I don't have kids or my kids don't want to know, or other scenarios where a patient might not feel they need to get genetic testing. Always ask those questions to your physician, and the reason is that now that the world of precision medicine is expanding so rapidly, if we find a inherited genetic mutation, or what we call it, it's also called germline mutations, that potentially can open up doors for treatment. So in the event that, let's say, a pancreatic cancer patient is found to have an inherited BRCA mutation, that might open up some treatment opportunity. All right, so this first bullet point here is saying that if a woman presents and has ovarian cancer, we would recommend genetic testing. So that's the scenario I mentioned, that there are some diagnoses that we're going to recommend it regardless of if there's a history of ovarian cancer in the family. It also affects the treatment of ovarian cancer, because if a woman has the BRCA mutation, it's going to open up a treatment opportunity for what's called a PARP inhibitor. However, there has been some new data that has come out probably since these slides that most women with ovarian cancer at some point are going to be candidates for PARP inhibitors, whether or not they have the BRCA mutation. So that's where some nuance comes in. All right.
Sorry.
Yeah, okay, we're good. Yeah, I think we're good. Okay. Are they going to get a copy of these slides by chance?
We're gonna make the slide available. Yeah.
Great. So don't feel like you need to take your pen and paper out and jot this all down really fast, because you will get this information. Okay. More questions?
Then yeah.
Okay. I'm trying to think of things that we haven't covered in this talk so far, and I think one thing I really want to emphasize is that there's still a need for chemotherapy or other types of therapies that aren't what are called targeted treatments. And what we're finding often is that there is a synergy or a nice complementary effect of combining a targeted therapy with a chemotherapy. So that is something that I don't think is going to go away. I don't think we're going to see the end of chemotherapy, but we are seeing less and less use of chemotherapy as we're introducing immunotherapies, targeted therapies, biologic therapies. I like to always tell patients that we need as many tools in our toolbox as we possibly can get, and then we're going to take out our best tool first, and then we're going to keep going down the line. And so this precision medicine is just adding more tools to our toolbox.
Perfect. I think the resources are ours. Is that what's up next? There we
Yes.
go. All right. Wow. You guys sped through like really complex topics so efficiently. I feel like live or when we're in person, it always like we take some time to get there. But please comment any questions still roll in as I share a little bit about your local resources. So if you don't know us already, please check out our website. We have a lot of great resources there. Of course, as many things are these days, we are not offering in person support right now, but we hope to as soon as we're able to and as soon as it's safe to. In the meantime, like I said, everything is virtual. We're offering all of our great support groups, our individual counseling, a lot of classes like yoga, Tai Chi, things like that are still offered all online and free. If you'd like to get started with us, you just send us an email and we'll get you going. So we are local in Templeton. We do offer a couple of support groups in San Luis Obispo right here at the UCLA office when we are doing it in person. What else? We offer a lot of things at our site that are also has to do with if you need hats and wigs and all those kind of resources, breast prosthetics, things like that at our office. We offer those as well. You can make an appointment even right now to come in and try those things on. So anything you're needed related to your cancer care, your emotional and social support, we probably have something we can help you with. So just reach out. Everything is free. We'd love to chat with you. Next one. And up next month, we continue this great topic. This is one that is actually featured one of the therapists that works with us that you'll see in some of our support groups. Lindsay Levinson is a licensed marriage and family therapist like myself, and she's also a 2-time breast cancer survivor. So she is going to speak from both of those hats that she shares and talk about different ways that we weigh treatment options, the social and emotional pieces that go into those decision-making things that, how your values influence that, good questions to ask your doctors, helps you kind of weigh those difficult decisions because being at the beginning of your diagnosis is sometimes the most daunting period of time. So it should be really great information. We'll bring it to you live just like we are now. And So yeah, keep tuned for that. It will be on October 7th, coming soon. A couple other things that have to do with cancer support community. We are a nonprofit that is local to you, but we are part of a wide web of other affiliates all around the country and actually all around the world. One of the things that headquarters likes to offer is a cancer experience registry. So if you wanted to share your story, insight about how it was that you got through your journey, medically, emotionally, all of those factors, getting on the registry helps to provide much needed data for that research to continue. So if you want to share your story, it's a really great way to be able to contribute back to data that helps further research for new therapies in the future. This is a little bit how to join. You can find that on our website as well. The next one is My Lifeline. So this is a little bit like the Caring Bridge, if you've ever used that tool. This is a way to capture your unique schedule for your treatment and share that with friends and family. Use it as a blog, a way to sort of keep up with friends and family about your treatment and your needs and how they can help be a part of that and support you all in one place. So it's a helpful tool to be able to navigate lots of moving pieces as you're coordinating your care. And then our funders. That's it. So I'm gonna take a peek real fast, see if we have any more questions before we wrap up. And because we have a little bit of lag on the camera, you might see a little dead air time, but I will get back to you.
Any questions?
Not yet. It's quiet.
Mm-hmm. Anybody want to sing?
You don't want that. At least not for me. Hey, it's still going.